even with tried and trusted x-rays. But x-rays I find extremely helpful, and there's the arrow just to help you all. This kind of thing is some ossified labrum. And again, it's a sign of unhappiness in a hip, really, and either a labral tear or a labral tear associated with impingement. And again, in a patient with hip joint pain, that's highly relevant, and is an indication for further imaging. I use MRI mainly to exclude non-acetabular rim conditions, because by and large, if the patient's symptoms are bad enough, they've had them long enough, and they're coming from the hip joint, I'm going to arthroscope them with or without doing some impingement type surgery. So I'm very keen not to arthroscope people with diseases that are masquerading as impingement, such as that, which is a stress fracture. It's also nice if you see labral cysts and labral tears, but I don't usually use contrast because I'm a hip arthroscopist. I think if you really want to see the articular cartilage, the best way of seeing it is at arthroscopy. However, if you don't have arthroscopy in your sort of young adult management, and there are some of my colleagues out there, then using contrast to look at the articular cartilage is very helpful. These are plain MRIs. This shows some anterior articular cartilage cysts. That's the front, that's the back. Correct me if I'm wrong, Simon, but there's some cysts in the anterior acetabulum. And again, this you can see, you've all got your eyes in now. You can see a big cam there, can't you? Yeah, really flat there. You could almost put a ruler along that. There's no way that's going to fit nicely into that hip socket, but you can see that there's a little labral cyst, a little bit of increased signal in the subchondral bone there associated with impingement. I love CT. I love it even more now. We can do CT movies in real time. It's really, if you're really serious about impingement, you've got to use a lot of CT. It shows you the bumps very well, but it also shows you some anterior chondral cysts from damage from the bump, and this is the point of impact between the front of the socket and the front of the femoral neck, these sort of characteristic impingement cysts that you see at the front, at the neck. And these are very good little signposts when you're doing arthroscopic surgery and you find the cyst. These are less sophisticated 3D views, but you can see the bump there. It's sort of triangular, really. You see it's sort of got a sort of a triangular kind of shape to it, the cam. Again, these are simulated movies. These are not real movies. This is so you can see, because we know it's simulated because the pelvis isn't moving. Because we know in real time, having seen Simon's one, that the pelvis does move. But this guy's got a cam here, but he's also got a little segment of ossified labrum there. So it's really going to hurt when he flexes up. You go a bit like the cam. Ow! Yeah, can you see that's really going to hurt there? And sure enough, if you remove that, it stops hurting, just like the ankle that we saw. So why operate on impingement? Well, the main reason to operate on impingement is because it hurts, and it stops people sitting at their desks, and it stops them running around. It stops them even commuting into work sometimes. So that's why we do surgery for impingement. Quite often the patients feel that the hip moves a bit more smoothly. You can't measure it, but they feel it's a subjective improvement in movement. Clearly, if you're improving the mechanics of the hip, it's likely to delay wear and tear or even prevent wear and tear in the hip completely. But I never sell patients like that, because you'll never be able to prove that. You know, you're not going to put 100 patients in a room with impingement saying, no, you've just got to suffer, and the other 100 patients can have treatment and then look at them 20 years later. That's never going to happen. So we're never going to be able to prove that. We can pick some surrogate endpoints, but it's never going to happen. And when do you operate? I mean, I think when it's worth operating on them, and it sounds simple, but you don't just operate on everyone with FAI. It's not a life-threatening condition. I see the tip of the iceberg, really. The vast majority of it is managed by physiotherapists, by osteopaths, by general practitioners, by personal trainers. And, sometimes the symptoms can be reduced dramatically with just a change in exercise schedule, change in intensity. However, if those measures fail and the patients have the appropriate imaging and they have symptoms that are sort of encroaching on their day-to-day life, then, surgery, is something to discuss seriously, really. Another group that needs surgery are elite athletes, because clearly if they're getting any pain running around or trying to do their sport, then that prevents them being in the team and therefore preventing them earning their living. So you try and muddle them along through the season with maybe a couple of hip joint injections and then operate on them as soon as the season's finished, if that's possible. Otherwise, if the injection's hopeless or doesn't work, then you just get on and operate them so they're ready for the following season. It won't come as a great surprise to you that the targets of surgery predominantly are moving the bump, the cam, to give you a nice round femoral head. These are some pictures from open surgery. You can also deal with any rim prominences, microfracture any cartilage injuries, and deal with any labral tears as well. And the traditional treatment is sort of open surgery, where you dislocate the hip, you gain access to everything, reshape the head-neck junction, and it's highly effective surgery. And it's an operation I still do, predominantly on teenagers actually, because I think you can get a perfect correction and potentially cure them of this condition. And because they recover much quicker, and 6 weeks on crutches for a teenager is no big deal. It's a much bigger deal if you're 35 and got 2 kids at home and a mortgage. So I still do open surgery on patients with very big bumps, big deformities, big rim problems, and as I say, in teenagers and adolescents. And this guy, I probably would do this guy arthroscopically now. This is this guy is a professional rugby player in Ireland, and we did open surgery on him. It's worked very well. He got back in the team, and he's delighted with it. And you can see the ball is nice and spherical. But I'd probably do him arthroscopically now. It's just one to just sort of, you see he's still got a little bit of a prominence there on the other side. You're saying that's nothing. I can tell you it isn't nothing, and it's subtle, but it's there. So I'll finish off just by talking sort of a bit about arthroscopic treatment of this, and clearly it's a huge advantage for everyone if you can do the same operation through little stab wounds rather than sort of a 6-inch incision. Certainly as you get more confident, you can take on more and more stuff arthroscopically, and it's my sort of standard operation for impingement now. You don't need to dislocate the hip. They're only in hospital overnight. If I did them in the morning, some of them could go home in the evening. They're on crutches just for a couple of weeks. Clearly hip arthroscopy is a hassle. There's all this stuff in the way. It's a small, deeply located joint, and you need lots of kit. If you've got I cannot underestimate the importance of teamwork doing hip arthroscopy. Everyone needs to basically know what they're doing so you can concentrate on the surgery. Because if you have to really, sort the staff out, tell the nurses where every single little plate bit has to go and explain everything, it's absolutely exhausting. Fortunately, I spent the middle part of last decade doing that, and now I have quite a nice life doing hip arthroscopy. This is the kind of setup. The patient's on their side, the x-ray comes underneath. That's kind of distraction that you need on the hip. You need between 8 and 10 millimeters just to get your scopes in. We attach the foot to a boot and then wind it up. So again, it makes Simon's medieval torture device look positively pale in comparison. This is a medieval torture device, Simon, and I'm sure your hips aren't hurting at all now, having seen that. And this is here we're arthroscoping. You basically put needles into the hip joint under x-ray to make sure you're in the right place, and put a guide wire in, then dilate them up with cannulated arthroscopes. And that's just the needle at the front, so that's water coming out of the hip joint. And here we are with a bit of action now. So that's the shaver here, and that's the scope there. And then the 3 portals are here really. That's sort of redundant, but they're just for the photo really, water coming out of it. That's the scope there. And that's a radiofrequency device, just clearing the capsule so that we get a good view of the bump. So that's just 1, 2, 3. That's all it is. This is the kind of thing that this guy's got a fairly standard sort of impingement bump here. This is the kind of view that we have. That's sort of the articular cartilage there, flaps of articular cartilage. We're buzzing that away with a radiofrequency probe. It seems I think I'm a bit quicker than that now. It seems terribly slow when I watch this. I think I'll do that a bit quicker now. And then when you've sort of got rid of it, you make a nice sort of sharp edge around the edge of the articular cartilage, just to give you a stable edge so that it won't pick up again. You won't trip over the carpet, as it were. This is the lesion now. Here's the femoral head here. Here's the socket. There's the labrum, relatively undamaged, but you see you've got this sort of quite a sort of about a 1 by 3 centimeter sort of area of articular cartilage, and this is about of the edge of what I think you should do. And so what you say, well, why isn't that just arthritis? Well, actually the rest of the hip looked fine. There's no articular cartilage damage of the femoral head. The remaining articular cartilage damage looked okay. This is a man in his early 30s. He's got a bad hip for someone in his early 30s with that amount of articular cartilage damage. But if you remove the bump and do microfracture of the sort of exposed bone, then there may be some hope, and there's nothing really better than that. Cartilage transplantation procedures for the hip are even more in their infancy than they are in the knee, and it's all very well growing articular cartilage, putting chondrocytes in, but it's getting that articular cartilage to mature and actually stick onto the bone that remains a problem. So this is now sort of a view inside the hip. There's the edge of the socket here. We've burred away the bump there, and there's a cyst coming into view. This is just, there we go, there's a cyst there. Can you see that? That's one of those impingement cysts I talked about. And they're sort of they're little like signposts, so like GPS waypoints almost, because you can see where they are in the scan and you can sort of correlate them. We're sort of burring away. We're just sort of finishing off with the burring now. We've obviously done the majority of it. That edge is the edge of the triangular shaped sort of extension of the cam. I'm just really sort of dabbing it really and just sort of looking around. But I find it easier to look with the burr still running for some reason. I just find it sort of slightly easier. I feel I can just sort of dab little things and stuff. So that's just sort of coming to the end. And the other thing is that you can actually, when you've done the correction, you can actually watch it in real time. And again, just to orientate yourself, this is actually a left hip. This guy's a junior. He's just got on the European Tour, actually, professional golfer, and then his hip started hurting. So hopefully he'll start again in January. But here's his labrum here. There's the femoral head. That's where his bump was. And as the hip flexes up, it can be quite difficult because you lose your view as you flex the hip up. But you can see that the ball is sort of clearing the socket there. It's not sort of colliding with the labrum anymore. It's difficult to get a before and after because you don't get such a good view of this until you've cleared a lot of capsule. It's just the way you do it. You gradually sort of accumulate the situation. So I think, fully arthroscopic bump excision is clearly the way to go. I think it's underrated in terms of technical difficulty. I think when you start hip arthroscopy, you're sort of led to believe that within a couple of cases you'll be able to do bump excision. I can assure you that it's not. It's a long learning curve. You need to be pretty comfortable at getting scopes in and out, looking around the hip before we can get started on this. And I'm very jealous of my fellow and my registrar who I'm teaching to do this operation. And I wish I'd had someone standing over me as I was learning it. But you can get hopelessly lost if you're inexperienced, and there's a completely inadequate bump resection there, and it's sort of depressing really. Surgical navigation could help when you're on the learning curve. But again, the problem with arthroscopic surgery, it's very difficult to register the skeleton. So I think, in expert hands, that arthroscopic impingement surgery is reproducible in terms of getting rid of the bump. It's effective. Harris hip scores improve. And I think if you look at series, the series with the better results are those where they're not really doing it on people with arthritis. And clearly, the earlier you intervene, as long as you're not doing trivial surgery of trivial symptoms, the better your results are going to be. And I think one of the advantages of the arthroscopic operation is that if you've got a guy on the borderline between sort of bad impingement stroke early osteoarthritis, if you look inside the hip and it just looks too bad, then you can kind of bail out and say, sorry mate, your hip's actually too far gone. Really, getting rid of your bump isn't really going to help you at all. And we may need to look at something in the future, such as an implant. I think there's been massive advantages in the understanding and diagnosis of patients with groin pain and hip pain in particular. And it's a common cause of hip injury in runners. And the great thing is that if you make the diagnosis, it's relatively easy to treat, and surgery is effective and available. And it's actually very satisfying. You've got to sort of x-ray the patients to death, really. I insist really on MRI, plain radiographs and CT. I think anything less than that, you miss things, and I've regretted not doing all three in the past, and that's why I get all three now if I'm going to operate on someone. And I think, don't rush into operating, though. The last thing you want to be doing is operating on every single impingement bump that you see. Far from it. The patients that get operations, as I say, the tip of the iceberg. Surgery is effective. If patients really need open surgery because you can't do what you need to do arthroscopically, please don't dabble with it. Undertreatment is demoralizing. Having one big operation is less disruptive than having one small operation and then a whole load of ineffective rehab and then another bigger operation. So, if you do need to do one big operation, and it's a conversation I occasionally undertake, you've just got to take it on the chin, and you have to persuade the patient that that's what they need to do. I think we still got a long way to go in terms of treating the articular cartilage lesions. Certain flaps you can stick down.